pressure, otherwise we would stroke out every single time anybody got excited or something stressful. Hello, welcome to Tala Talks NICU. Today we're going to be talking about IVH, or Intraventricular Hemorrhage. Marcus Wodaji and Vishmajit Das, hope I pronounced those right, asked us to cover IVH, so this is for you as well as for anybody else who might be interested. So today we're going to go over the description of IVH, the anatomy of the CSF and the brain, the causes, the prevention of IVH, the symptoms when infants get IVH, the diagnosis and the staging, and then we're going to go over the prognosis. So why do we care about IVH? We care because we are very bad at predicting the developmental outcomes of premature babies in the NICU. And so we use brain bleeds as a proxy for the developmental outcomes. Fortunately, the outcomes after bleeds are now much better than those first documented by Dr. Papil, who came up with a whole grading system. We used to think that if babies had bad bilateral grade 3 bleeds or a big unilateral grade 4 bleed, that the outcome would be bad enough that we should consider redirecting care or withdrawal of care. Now we know that really, even with severe bleeds, there's still a good chance of having a very good quality of life and a pretty normal outcome. So about 25% of very low birth weight babies, so babies less than 1,500 grams, will end up with an IVH. And about 5% will end up with a severe IVH. So that severe is considered grade 3 and grade 4. So obviously we have to screen all babies because they're all at risk. So now let's go over the anatomy. You have to understand the anatomy of the brain to understand the IVH. So first of all, let's talk about the ventricular systems. The ventricle carries the CSF, so they're fluid-filled pockets in the middle of the brain that go down the brainstem and then around the spinal cord and around the brain. And the CSF is responsible for cushioning the brain, so if you move your head, it's not banging against a hard surface. The lateral ventricles are the two big pockets right in the middle of the brain. So really they're like the first and second ventricles, but they're the same size, so they're just called the lateral ventricles. Then it goes down to the third and then the fourth ventricle, and then around the rest of the spinal cord, that's where the rest of the CSF goes. The germinal matrix, which is where the bleeds pretty much originate from in IVH, are small areas just lateral to the lateral ventricles, so further out from the lateral ventricles, near the head of the caudate nucleus. And the germinal matrix is responsible for germinating, so creating new neurons. So it's a very, very blood-rich area. And it's very metabolically active because you can imagine that you need a lot of oxygen and a lot of nutrients to make these new neurons. The germinal matrix pretty much resolves completely by between 32 and 34 weeks, as in a lot of those neurons that are made have already been made and that area is not needed so much any longer. Clinically, that means two things. The first one is that the chance of having an IVH after about 32 weeks goes down significantly because that germinal matrix isn't really there anymore. The second thing is that because eventually that area goes away, in childhood or adulthood, there isn't a direct blood supply going to that area. So instead, it's kind of considered a watershed area. There isn't a main artery going there. Instead, there are little tributaries from the different arteries. So you can imagine that if there is suddenly a drop in pressure or there's less blood, then that is going to be the first area that's affected because it's not directly off a main pipeline of a main artery. So let's talk about the causes of IVH. So like a lot of things in neonatology, there isn't one clear-cut reason why babies get IVH. Instead, the etiology is more multifactorial. But there are three main factors that contribute. The first one, like we talked about already, is the inherent fragility of that germinal matrix area. Like we said, it's very blood rich, so if there's going to be a bleed anywhere, it's most likely going to be right there. And also, because it's so metabolically active and it needs so much oxygen and so much nutrients, if there's going to be any issue in not getting enough oxygen to different areas of the body, then the germinal matrix is going to be one of the first areas that gets affected. So like I said, just the inherent fragility of the germinal matrix. 2 is changes in blood pressure inside the blood vessels inside the brain. So normally in older kids and adults, there is a very tight cerebral autoregulation, which means that the brain really tries to make sure that it's getting exactly the same amount of pressure throughout its blood vessels. So even if your blood pressure in your body shoots up, the brain arteries are going to clamp down to make sure that the brain isn't seeing that pressure. Otherwise we would stroke out every single time anybody got excited or something stressful happened. In babies, that cerebral autoregulation is not as perfectly automated. So with increases in pressure in a baby, there's going to be slightly increased pressure in the brain. If there's a decrease in pressure in the baby, then the same thing is going to happen as well. What's even more concerning is that having hypoxia or acidosis further throws off the cerebral autoregulation, which also really kind of makes sense, because if you think about it, if your body isn't getting a lot of oxygen, then you want the blood vessels in your brain to dilate to try to get as much of that blood to the brain as possible so that the brain cells still get as much oxygen as you can. So you can imagine if the baby is hypoxic, for example, so those blood vessels are really dilated, and then suddenly the blood pressure in the baby shoots up, then what's going to happen? All that extra blood is going to be forced into the brain, and you're going to have a much higher chance of having a bleed. So logically, having very big shifts in blood pressure or hypoxemia or acidosis or hypercarbia or even alkalosis is going to shift those curves of the cerebral autoregulation and make the brain even more sensitive to having bleeds. So that's the second main big reason for why we have bleeds in that area in the baby's brain. And then the third one is having coagulation or platelet disorders in a baby. You can imagine that if your platelets are really low or you have factor VIII deficiency, so hemophilia, you're going to be at increased risk of having a bleed in the brain. This very rarely comes into play apart from in utero. One of the main causes for having an IVH in utero is if there is some sort of reason for why the baby has severe thrombocytopenia. Normally that will be because of NATE, neonatal alloimmune thrombocytopenia. So if a baby's born with an IVH, that's pretty much the first thing that we're thinking about. So let's talk about prevention. Like pretty much everything else in neonatology, the smaller the baby, the younger the baby, the higher the risk of the 3-letter acronym. Go look at the acronym video. So obviously the best way to prevent IVH would be to prevent preterm deliveries. We're not great at doing that in America. It's still about 12% of all deliveries. It's at least stayed stable for the last few years. So really number one would be to prevent preterm deliveries, or at least less than 32 weeks. Number two, and this has made a massive difference in the amount of IVH, is prenatal steroids. So the mother receiving the full course of the prenatal steroids prior to delivery, so the betamethasone 24 hours apart, so at least 48 hours prior to delivery, reduces the incidence of IVH by about 50%. So that is pretty much the most effective thing that we've had in reducing IVH in these preemie babies. The third thing that has recently shown to be very promising is doing delayed cord clamping. So doing delayed cord clamping for 30 to 60 seconds right at the time of delivery has also been shown to decrease IVH. Maybe because you're having a more even amount of blood in the baby and you're less likely to have the blood pressure shifts. We previously thought that indomethacin in slightly smaller doses than we give for PDAs does prevent severe IVH, so grade 3 and grade 4. And we used to give babies indocin prophylactically after they were born to try to prevent the severe IVH. However, later studies showed that even though it decreased the severe IVH, it didn't really affect the eventual neurodevelopmental outcome. On top of that, we found out that babies that received indocin had a slightly increased risk of having spontaneous intestinal perforations, where their intestine just pops. So we pretty much stopped doing that. And then really the most important thing that we could do is try to have as stable a baby as possible. So a mother hopefully would deliver after she received the steroids in a very controlled environment. So baby's not in a lot of prenatal stress, not having a lot of decels. Mother hopefully doesn't have any chorioamnionitis. Mother is delivering in a hospital where there is a NICU team readily available. Obviously we don't want mother delivering in an ambulance somewhere or in a car park somewhere where the baby's going to be a lot more stressed. And then immediately after birth, that golden hour, immediately after the baby's born, if we try to keep everything as stable as possible, make sure the baby doesn't get too cold, make sure the first sugar is good, make sure that it doesn't take hours before all the lines and everything is put in and the baby is stabilized, that also really does affect the incidence of IVH. So the overall stability of both the mother and the baby affects the incidence of IVH. So what about the symptoms of IVH? Interestingly, in about 50% of babies with IVH, there are really no symptoms at all. And then in the majority of the remainder, the symptoms can be really subtle. So a little bit of pallor, maybe a few increased A's and B's, apneas and bradycardias where the baby stops breathing or the heart rate goes down, maybe a bit of increased work of breathing. As the IVH gets more severe, you can imagine that the symptoms could get more severe. So to the point that there is marked anemia, which could result in hypertension, or you're just seeing the hematocrit actually drop on the blood draws that you're doing. Or you could end up having more severe neurological symptoms, anything from a little bit of irritability to lethargy to the baby just being limp and not even spontaneously breathing. If the IVH is severe enough, then you will start feeling some bulging of the fontanel as the ventricles are being more and more filled with blood. That's going to put increased intracranial pressure on the brain, and you'll start feeling the manifestation of that increased intracranial pressure on the soft spot, on the fontanel. So now let's go over the diagnosis and staging of IVH. So like we already said, in about 50% of cases, there are literally no symptoms, even if a baby does have a brain bleed. So we have to get ultrasounds on every single baby, whether they have any symptoms or not. So the standard of care is that all babies who are born at pretty much less than 32 weeks and 1,500 grams, and different units change this slightly, get a screening ultrasound at between 7 to 10 days of life. So we're able to do the ultrasounds on the preemie babies because, like I said, they've got a soft spot, so they have a little window to their brain. Obviously we couldn't do an ultrasound on an adult because it's all skull there. But on all babies born at less than 1,500 grams, less than 32 weeks in most places, we get a screening ultrasound at 7 to 10 days. And then they all need a second ultrasound at about 36 weeks to make sure that the baby's brain has developed normally and there hasn't been any PVL developing. So I can talk about PVL in a future topic, but for now, what we're concerned about is the sequelae of any bleeds or abnormal development in the brain. If the baby does end up having a bleed, then we need to get ultrasounds a lot more often because there's then an increased risk of post-hemorrhagic hydrocephalus, and I'm going to talk about that in a second. For now though, the first ultrasound should happen at between 7 to 10 days of life, and you definitely need at least one more ultrasound before discharge, normally at 36 to 40 weeks. So what are the different grades of the IVH? Grade 1 IVH is when you just have a bleed at the level of the germinal matrix. So it's not going into the ventricle at all, just at the level of the germinal matrix. What's very confusing about the grade 1 bleeds is the germinal matrix is situated right next to the chori plexus. The chori plexus, as we've already mentioned on a previous topic, produces the CSF. So remember it, chori plexus, CSF producer. And it glows very white on the ultrasound. Whenever we see a bleed on the ultrasound, basically what we're looking for is areas of echogenicity, so where it looks really white. So very often, a chori plexus, which is right next to the germinal matrix, can make it look like there is actually a bleed in the germinal matrix. So we're probably not very good at calling grade 1 bleeds on the ultrasound. Not that we need any further imaging to call it, but on a grade 1 bleed looks very much like a brightening of the chori plexus. A grade 2 bleed means that there's blood in the germinal matrix that is then kind of burst through the ependymal layer of the ventricles and now has gone into the ventricles. And a grade 2 bleed is when there is blood in the ventricles, but it fills less than 50% of the ventricles and there's no dilation of the ventricles. A grade 3 bleed is basically an extension of a grade 2. So again, there's blood going into the ventricles, but now that blood is taking up more than 50% of the volume, and there's now some dilatation of those ventricles themselves. So that is a grade 3 bleed. And just as a reminder, you can have unilateral or you can have bilateral. So if both ventricles are filled, then you've got bilateral grade 3 bleeds. If it's one ventricle, then it's only the left or only the right, grade 3 or grade 2 bleed or whatever. A grade 4 bleed, a lot of people think is kind of a very different type of etiology. But basically a grade 4 bleed does not necessarily involve blood in the ventricles at all, but it's where there's such a severe insult that's happened that there's now bleeding in the cerebral cortex. So you've actually got blood in the brain matter itself. Very often it's because there is so much blood from the grade 3 bleed that you've had an infarct in the area of the cerebrum. So it kind of is like a stroke in the cerebrum. So grade 1, germinal matrix, grade 2, grade 3, blood inside the ventricles, grade 4, blood inside the cerebral cortex. Now let's talk about the prognosis. So like I already said, we now know that even with severe bleeds, the developmental outcomes are not as bad as were originally documented. Now what we know is that it's not even so much the bleed itself, but what happens with the bleed? Does it go away by itself, or are there any other sequelae after the bleeds? So there are two big things that we worry about. The first one is a post-hemorrhagic hydrocephalus. So post means after, hemorrhagic means the bleed, hydrocephalus means that the ventricles are now filled with fluid. So what we worry about is that the blood from a grade 2 or grade 3 bleed, remember, those are the IVHs that actually have blood within the ventricles. What we worry about is that blood, instead of being reabsorbed by the baby and then just slowly going away and then ending up with pretty much normal brain growth and development of the ventricles, instead of it going away, it somehow clogs up the ventricular system. And so the CSF can't be drained, and so the cerebrospinal fluid slowly builds up in the ventricles. So this can happen in two ways. The blood hopefully should get absorbed. If it's not getting absorbed, then the first thing that can happen is that the blood drips down through the lateral ventricles, through the third ventricle, and then the narrowest area of the ventricular system is the aqueduct of Sylvius. So it's possible that the blood ends up getting sticky and clotted in that aqueduct, resulting in the CSF not being able to drain normally. So then the CSF starts building up in the ventricles and you end up with hydrocephalus. So that's one way that the CSF stops draining. The second way is that the blood could go and layer over the arachnoid villi. And the arachnoid villi, remember this because it's are responsible for absorbing the cerebrospinal fluid. So if the blood is laying over the arachnoid villi and irritating them, they no longer work properly and they're no longer absorbing the cerebrospinal fluid. So the cerebrospinal fluid builds up and builds up and builds up in those ventricles. So what's going to happen? It builds up in those ventricles. The brain tissue around the ventricles is a lot more compliant than the skull. So immediately the ventricles are going to start pushing on the brain tissue and effectively squashing the brain tissue. Eventually that brain tissue will start pushing on the skull, and the skull will start growing at a much larger rate than it should normally be growing, which is about ½ centimeter a week, between 0.5 and 1 centimeter a week. So definitely we should be following the OFC, so the circumference of the skull, in all babies that have a brain bleed. About 30 to 50% of babies with severe grade 3 and grade 3, grade 4 IVHs. Remember, if you have an isolated grade 4 IVH, you can't end up with post-hemorrhagic hydrocephalus. But babies with grade 3 and grade 3, grade 4 IVHs, about 30 to 50% of them are going to end up with some level of post-hemorrhagic hydrocephalus. And in a minority of those, so in about 20 to 40% of those, they will need some permanent drainage system to make sure that that pressure isn't staying on the brain all the time. In the tiny babies, we need to be able to take some of that CSF out so that we can remove the pressure on the brain. Most of the time, it's an obstructive hydrocephalus. So a long time ago, it was suggested that we could just do serial spinal taps. But as you've probably figured out from what I've already said, the level of obstruction is normally above the spinal fluid. On top of that, you don't constantly want to be tapping a baby. So in these tiny babies now, if they do need some of that pressure to be evacuated, then they end up putting in a ventricular reservoir. So the neurosurgeon will put in this little kind of area right above the ventricles, just allowing an easy access to the ventricles. And you can go in every day or every other day and just tap out, so kind of puncture it, and then tap out about 10 cc's per kilo to try to remove that extra pressure of the CSF on the brain, and therefore allow the brain to grow normally instead of having this constant pressure pushing on the cerebral cortex. Eventually, when babies are big enough, then they can end up with a VP shunt, which is a ventriculoperitoneal shunt. So it's this tubing between the ventricles going under the skin all the way down to the peritoneal cavity. So the excess pressure is constantly being drained into the peritoneal cavity, which is much better at absorbing that fluid. So you can imagine from a prognostic situation that if a baby has a grade 3 and then it slowly goes away again, the brain continues to develop normally, the head growth is normal over the rest of the hospital stay, and all the blood is absorbed in the ventricles. That is going to be a very different outcome from a prognostic standpoint from another baby that had the same grade 3 bleed that ends up with getting the post-hemorrhagic hydrocephalus, that needs a reservoir for several weeks or months, getting tapped every other day, and then finally needs a VP shunt. Obviously, the effect on the brain, as well as just the overall inflammation, is going to be much worse in the baby that ended up with a post-hemorrhagic hydrocephalus. The other big sequelae that we worry about is the development of PVL, or periventricular leukomalacia, and that can happen most commonly in grade 4 bleeds. So leukomalacia is basically where you just have scarring in the brain matter itself right around the ventricles. It's either scarring or it's so bad that the neurons just aren't there anymore. They're being completely destroyed. And that is when you end up with poor encephaly. So when you're looking at an ultrasound, it just looks like you've just got a hole in the brain, or that's when you have the cystic PVL. As you can imagine, if you're missing entire chunks of the brain like that, then that is definitely going to affect development. And the babies with the PVL, especially after the brain bleeds, are the ones that are going to have the worst developmental outcome. So now we know that what happens after a baby gets a brain bleed is a lot more important than the size of the bleed or that initial bleed itself. Not just that, but all the other things that affect the baby, exactly how sick the baby is, all the blood pressure issues the baby had, all the infections that the baby gets. Those are just as important as the bleeds that happen inside the baby's brains. However, as you can imagine, if a baby does have a bleed, especially a grade 2 or grade 3, it's going to be very important to follow that to make sure that the baby does not develop post-hemorrhagic hydrocephalus. So if a baby has a bleed, then we would need to follow up with ultrasounds every 2 weeks or a week or every 3 weeks until that bleeding goes away, or until we reach the point that we all decide that this is affecting the brain tissue too much, the hydrocephalus, and we need to intervene somehow. So if a baby does have a bleed, then they're not just getting the first ultrasound at 7 to 10 days of life and the discharge ultrasound, they also need to be followed consistently to make sure that they're not developing hydrocephalus. I hope you learned something today. It's an absolutely massive topic. If you'd like me to talk about it more or talk about different aspects in more detail, then I'll happily do that. I am going to talk about PVL separately at some later stage. In the meantime, please like and subscribe and comment below with other topics you'd like me to talk about. Thank you.